Welcome back to Plenary Session. This is episode 8 of the Malignant Book Club. I'm joined by Dr. Timothy Olivier from Geneva Hospital.
Hi, Vinay.
Hi, Timothy. It's good to see you again. We have been spending a lot of time getting into the book Malignant. And
so today is an important episode, short episode, I think.
oh, good. Let's keep it short.
Yeah, we are finishing section 3 of the book
Okay.
by the chapter called Global Oncology.
Global Oncology, my
So,
favorite.
Global Oncology.
My favorite topic.
And next episode, we will starting the last section of the book with solutions.
Solutions. That's what people are waiting for. You know, I got to admit, it's a lot of, we haven't even talked about everything in the book, and we've talked for so many hours. There's a lot in there. It's a lot. It's a dense. It's a dense product.
And rereading it, there's a lot of things.
I feel like I'm losing my mind sometimes because I feel like, did I say this already? And I was like, yeah, I did say it already. I said it at least once, twice, 3 times, said it in the book. And now I'm like reminding myself of my mentality in the moment, but also my mentality today.
But the idea of this series is really to say what you wrote in the book, even if you say this in other episodes, other topics.
You're right.
It's really to give a sense. People can really just follow this series
Yes.
and see what is in the book.
And maybe ideally, you could listen to a chapter and then listen to the audio, and they kind of complements each other.
Yeah.
All right, so take away. We got Global Oncology.
Yeah. So I think as an introduction, you remember having some students and asking them what do you think is the definition of global oncology. And this is the introduction, and I see you're starting
I'm reminding myself.
Yeah.
What did I say? Oh, yes, of course. Well, it's a bit cynical, but you should expect no less on this podcast. But, there are so many people who say they care about global oncology. And I think I start with the vignette that I think if you interviewed applicants for oncology or residency or medical school, I want to do global onc is something that everyone keeps saying. I like global onc, global onc, global onc. What do they mean by global onc? I think for a lot of people, and I hate to say this, it means I want to live and work in a cosmopolitan U.S. city or European city. I want to live and work in a very, very nice city, and have all the luxuries and amenities of Europe, of Western Europe or the U.S. I want to occasionally, once or twice a year, fly to some part of the world and practice a little bit of oncology with a little bit of limited resources. And then the moment it's over, I fly all the way back here. And I think, I say that that's cynical because I'm not sure how much you're helping people in other countries if you just parachute in, deliver this sort of a little bit of aid, and shoot out. And, I've heard so many horror stories of people who did global health where they had, they don't even have the tools to treat something. Somebody once told me that they treated a DKA with a Gatorade. And I'm like, are you even helping anyone if all you can offer is a Gatorade? A Gatorade and a metformin or something like that. That's ridiculous. That's not how you treat DKA. So I guess I open with that to say that I think throughout history, Western nations have preyed upon the globe to serve not the interests of the globe, but even the interests of Western nations. And I think to some degree, even global oncology, people who think they're helping the world, to some degree, they're also preying upon the world. And so in this chapter, I hope to try to say, what does it actually mean to do right by all nations in the world, to do right by all people in the world, and do right for people in our country, because I think some of the things we do over there actually make it worse care in the U.S. So we'll talk about that.
Yeah, so the first point you make more clear, and you talk about this in the first chapters with quality of life and cost effectiveness analysis, but here's the new concept of affordability. And so affordability is related to what each nation can really afford as drugs. It's not just the price of drugs. Even if the drug is cheaper in some nation, it's so much expensive as compared with what people can really afford.
Yeah, so one thing people say is we always pay the highest prices in the U.S. Well, does that mean that the drugs are the most unaffordable here? Unaffordability is a product of how much money people have and what the relative price of the drug is. And I believe it, and I can't remember off the top of my head, it's Dan Goldstein who did a nice paper where he looked at where drugs are most unaffordable. And where was the answer?
India and China.
India and China.
Yeah.
So it's actually sort of the rising economies of the East where the drugs are priced higher than the average household wage by the greatest difference. And that's sobering. And the reality is the proof is in the pudding. You take all these great drugs. There's so many great drugs. The truth is the vast majority of people in the world are not getting access to these drugs. The only access they may have is they run a multinational randomized control trial. You get randomized to control arm or the treatment. The moment the trial's over, they stop, they fly out of the country, and guess what? That treatment, even if it's approved in your country, often you really don't get access to that drug. It's not really available. It's not actually affordable. It's not actually available for people in that country.
We are really going to the core of this chapter. So the core of this chapter is when a trial is run globally, and you separate two different types of trials that are run globally. You give the example of HIV trials.
Mm-hmm.
Interesting. You give also the example of a cancer screening trial in India.
Mm-hmm.
And also you will give some examples of trials that are run globally to seek market in the US and all these issues. So I just put all the subjects together, but I know you will tease this apart. And this is really the core of this chapter. We say global oncology, but it covers many, many types of trials. And sometimes trials should be done globally or in low or middle income countries. There are some conditions for that, but sometimes it's maybe unfair, that is to say.
I mean, I think that, one big distinction is the trial being done for the benefit of the people in those countries or not? And if the trial is being done for the benefit of the people in those countries, as I think the SHAS-3, acetic acid screen of the cervix trial was meant to. It's a randomized control trial of screening in the Mumbai slum. In the Mumbai slum, the cervical cancer screening is currently nothing. They can't afford the Papa-Nicolau smear. And SHAS-3 comes in, he randomizes people to visual inspection of the cervix. It's not even a doctor who does it. It's like some mid-level trained, some healthcare worker, some sort of just a lay person who's had some training. And he shows them how to do it, and they do it, and then they follow these women out for many years, and they show a reduction in cervical cancer mortality from doing that. Now, people in the U.S. were critical, say, why isn't the control arm Papa-Nicolau smear? And the answer is, of course, well, we're not doing anything right now. We can't afford Papa-Nicolau smear. And we wouldn't even be able to afford it as a control arm. And what we have found is something that's better than nothing, which is what we're currently doing. And it was done by us and for us, and it meant to benefit the women in our Mumbai slum.
And also, it was potentially doable.
It was doable.
It was
feasible.
Scalable.
It was scalable.
Yeah.
And then
that was also an important.
Yes, it's an important point that once the trial results as a positive, you can actually implement it, and they can afford to do this. And so I use that as an example of, in a perfect world, I do think people in India should have access to the Papa-Nicolau pap smears, but this trial was done by them, for them, with the available constraints, and it is progress. It's not backwards. I've seen there's some, ethicist people, the typical armchair ethicist people who said this trial is wrong. I was like, well, if you wanted to live in your world, they would still be doing nothing in the Mumbai slum, and now they have something that's scalable and doable. And I contrast this. Okay, so this is, I think, a good example, and there's some other good examples. Really by us and for us, by us. That's the key. It can be done, I guess, by anybody, but it has to be for the people there, scalable, implementable, make their lives better than what it is right now. I think that's great. Now, the other side of the coin is, what are we really doing? What do we mostly talk about on this channel? Multinational randomized controlled trials that are primarily designed and conducted for regulatory approval in the United States and in Europe, certain nations in Europe, the nations that have the cash, and they happen to accrue globally at all these sites. And they're not for the people in those countries, and they're actually not even for us, because they run them globally with control arms beneath what our standard of care is, with post-protocol care that's negligent and delinquent. And so ultimately, it actually doesn't give much information for a United States person making the choice, because our post-progression therapy isn't nothing. Our post-progression therapy is the next available drug. And so they're giving us information that really favors the drug product, but doesn't actually inform the patients in the U.S. It also doesn't help the people in those countries. Why? Because it's not scalable. The moment the trial ends, you can't afford ibrutinib or venetoclax or you name it. It's not scalable. If the drug was available in all those countries for pennies, then I would say, then it's great. Then it affects their practice, but it doesn't affect their practice. I think I saw somebody tweet this year, after our trials close, it's the last I'll ever see that novel drug. This is somebody from Brazil, said the last I'll ever see it. Because the company just makes it, like we talked about, it's unaffordable in that nation. And so, so people who justify this practice, they say, well, if we don't run the trial at all, then even the people in the experimental arm wouldn't get that drug. And I say, you're selling the people of your country for very little, just for a little pittance from the company. You have all the bargaining power. They need your patient population. You should demand that they make the drug available after the fact.
And also you make this point in this chapter, is that if you would regulate differently, this would incentivize totally differently the trials, and so you would have more. It would be more fair globally. I mean, you can case by case say that, but this is also a question of incentives and how you can incentivize better trials.
Yeah, if the U.S. FDA just said, we'll allow you to run the trial in the U.S., but you can also run it globally. But you have to make sure if you run it globally, they have all the same staging we do in the U.S., all the same post-protocol care, et cetera, et cetera. Well, then the company's in a pickle because they're going to have to make a huge investment in the infrastructure, make their drug available, make sure people have access to scans if they want to run it globally, or they have to run in the United States where they have all the sort of challenges and the cost there. But I think the information will be more useful for people in the United States. That's a minimum. There may be the drugs that come to market will be the most, the drugs that actually work. And I think that the issue of what to do about global inequity is a deep issue. I mean, it's beyond the book of Malignant. You're not just going to be able to solve it with this, but we need to realize that our current system thrives on the exploitation of low and middle income countries. It is exploitation.
Can you give maybe an example, maybe the example of the book or other examples? There are so many, but the example of such trials conducted globally where you can clearly see that the control arm or the subsequent treatment is inferior to the standard of care.
Yeah.
In the book, you talk about afatinib and
yeah, that's been a long time since I've reviewed that.
I guess
randomized trial of nivolumab versus dacarbazine after IPI was the standard of care. That's a good one. Even this, what was it? The ivosidenib, the Agile study that we just published on. Ivosidenib AZA versus AZA. Then venetoclax comes around. It changes the whole landscape. We all change our practice. And then they just stop accruing in the U.S. so they can continue their control arm of AZA. And then they use that trial for U.S. approval. Are you kidding? You stopped enrolling in the U.S. because you admit the control arm could not possibly be feasible here. And then you still submit it for U.S. approval and you still get it? And if the trial's over, guess what? I cannot imagine there are many people in those nations who are routinely getting access to ivosidenib.
Was it nivolumab against dacarbazine that was approved on the accelerated approval pathway because no patient was included in the U.S.?
Okay, maybe in part, but yes.
No.
But I don't know if that was the distinctive reason. But it was. They did do the randomized trial. They did find the benefit, but then they took the single arm and gave accelerated approval.
Yeah.
One argument might be that the FDA said, "Hey, you're not accruing anyone in the U.S." I'm not sure that was it versus the fact that they just thought it was just it was one of the few examples where they were like, "My God, this is delinquent," and but they had the legal authority to halt it. They chose not to. We'll talk about that, I think, in a future chapter.
So these are the main points. I think you finished the chapter with two examples, very good example of trials run in India. The one that tested if mastectomy in the metastatic setting was improving outcomes or not in patients with metastatic breast cancer.
And that's another one from Tata.
And the other one is the dose and regimen of concurrent chemotherapy in head and neck cancer.
Oh, I put that in there? Wow.
Yeah.
I feel like it's more updated than I thought. Yeah, those are two great examples. I mean, I think the chapter ends on a positive note, which is that, I think all nations in the world can contribute to scientific scholarship. You don't have to just be in a high-income nation. We happen to be in high-income nations, but actually all our scientific scholarship could be done in a low-income nation because we don't really utilize a lot of the really high-cost products and high-cost interventions and high-cost science. What can low- and middle-income countries do that only they can do? They can do really fundamental, simple, elegant, randomized controlled trials. What was one example? The Tata Memorial Hospital randomized women with metastatic breast cancer to removal of the primary breast mass or not. Keep in mind, this is metastatic breast cancer. The horse has already left the barn. This was something that was heavily debated. In the United States, we did a lot of it. There are many, many observational studies that compare outcomes of women who had the primary removed when it was metastatic. I think altogether 35,000 women contributed to those studies. They took over, 35 years, I think. And then the Tata group, with just a 10-year randomized controlled trial, showed conclusively there is no survival benefit from removing the primary in breast cancer. I think that and another study, was the end of it. And it really did stop that practice in all but the rarest cases where you have a fungating mass, et cetera, et cetera. It stopped it mostly. That was elegant. That was a New England Journal paper that came out of the Mumbai group. Even the Shastri paper, I think, was published in JNCI, but it was still a very important paper. Low and middle income countries can do some of the trials the U.S. is scared to do, which is to see if what we're doing in a disease where it was based on sort of eminence-based medicine, things being passed along, if that actually works, if it could be scaled back. Those trials of surveillance could be done in low and middle income countries, actually. Many of the surveillance trials that we talked about in the prior video could be done. But instead, there's a temptation that a low and middle income country should sequence every tumor, just like, because that's what the high income countries do. I think that's misguided because they're never going to be able to have the resources to sequence as deep and as many, as often, as frequently as we do. That's a misguided research strategy. They should focus on the questions that they alone can answer, questions relevant for their population. And I think they should say no to the exploitative U.S. studies, the regulatory studies. It makes a lot of people rich, In this country, we have more financial disclosure. If you started to trace the money in some of these countries, I think it might be quite concerning. In making people rich, these trials are not helping anybody. They don't help people here, and they don't help people in their country because at the end of the trial, they don't have access to the product. And so I think that's an ethical framework that Sham and Hemnath and myself wrote a paper on in JGO, an ethical framework for this, and we kind of build these ideas in this chapter. I mean, this is a tough chapter in the sense that, I'm somebody in a high-income nation whose parents are from a low-income nation, who cares deeply about the fate of people in the world, and who thinks that a lot of people whose heart is in the right place are doing something wrong. And in this chapter, I'm trying to weave together all these themes, my experience, my thoughts, my feelings, and I'm trying to build the argument for which trials are good and which trials are bad. And as you talked about, I mean, that's a tough distinction.
Yeah, that's a tough I think one core question is the trial will be informative for your practice or for the practice here or there. But here, the example you provide, they are non-informative even for the people where the trial are run, and not informative for the US. So this is really problematic when this happens.
It's really problematic. I don't know why we accept it other than the FDA what we talked about earlier in the book, that the FDA is really fundamentally captured by the industry. I don't know why trialists think it's acceptable. And I really think as a doctor, the more, we always make this point, how does this affect your clinical practice? The more you're aware of these differences, can you really hang your hat on, let's just say, PD-1, 0% head and neck cancer, Keynote 48? Is that reliable for your person? Even PD-1, 4%, 5%. They have poor post-progression therapy on Pembro in Keynote 48. So many trials that people are just, they get the trial, they hear the press release of the trial, they start practicing that way. If they really understood deeply the limitations of the study, there's a lot of caveats for the patient in front of them. Javelin 100.
Yeah.
Javelin 100, that's a great example. Bladder.
Yeah.
Post-protocol, Pembro was very poor.
Recently, we talk about in the adjuvant setting of Checkmate 816 and at Empower 10, post-protocol treatment is very low.
And even adjuvant Pembro and RCC. Yeah. All the adjuvant studies, we have that preprint out with Claire that we're seeking publication on, I think. Actually, maybe it got published. It's hard to keep track. These are key deficiencies.
And post-protocol is very, very important, I think.
Explain them.
We're talking about in
more.
In solutions.
Okay. So what's else? That's it for global oncology.
Final thoughts of the section and or the chapter, global oncology.
Final thoughts. I recently saw something interesting where a team of authors made some claims about the nations in which trials were enrolled. And then I saw some snarky feedback, which was like, oh, how many of the PIs of this study are, from low and middle income countries? And I was like, whoa. Look, we got to be very clear. One, that's an ad hominem argument. You're not actually refuting the central points of the paper. You're talking about the characteristics of the people who wrote it. If you make an ad hominem argument, you are arguing poorly. People shouldn't take that seriously. I also want to get another point. I do think it is important that we have better, representation at academic conferences and in publications. We do want to. No one should discriminate against a paper because it comes from, China or India or Brazil. Like your peer review process should be fair and just. Similarly, though, you can't delegitimize a study if it happened to have few people who are currently working in those other nations, if the points that it's making are true and accurate. And I looked through the author list of that paper, and even though many people were not working in low and middle income countries at the moment, it looked to me like maybe half the authors were born and raised in a low and middle income country, and many of them have families still there. And they're writing the paper because they care about people there. And we're writing this book because we care about people in India and Brazil and people in the United States. So we care about people in these countries, and we're using our reason and our faculties to try to make the best argument. And so this kind of, you don't have stature to say this argument, rebuttal, it's cheap. I think it exploits something else. It exploits a legitimate need for representation with a cheap way to try to dismiss and evade a targeted criticism. And the people making it were the same trialists who have run the unethical studies. You've made a career out of running studies that prey upon low and middle income countries, and you want to dismiss the criticism of that because it's not coming from there. Well, you know what? Whomever is giving you that criticism, you need to take it to heart. And I do think on this one issue of all the issues in the book, as the years go on, we always see in, like, this is the last thought, I'll end with this. There are many historical figures in America, maybe every country on earth, that did a lot of great things, but they also have some things that by modern standards, we look back and we're like, oh boy, how did they do that? That person in 1776, how did he do that? And you say, boy, what a bad person. Okay, so morality evolves, and also at the time, though, probably some people knew that, like, hey, that's not a good thing to do. This is going to be the issue that 100 years from now, people look back on these trialists and say, come on, man, you took an oath, you're a doctor, and you just ran trial after trial. It didn't help the people in your country. It didn't help the people in the country you ran it in. You did it because the company was giving you hand over fist money. I mean, come on, man. What are you doing? And I think it's going to age really poorly. So I think it's a really important chapter. My points are, I'm writing it because I care, and the people who wrote that paper, they got criticism, they care. And you have to be very careful what is ad hominem versus what is actually about the substantive argument.
Mani Mohyuddin published a very interesting paper on that.
That's the one I'm talking about.
And we will be publishing also. Mani Mohyuddin is making also another point.
A different point.
About approvals.
Yes. But that's what I'm talking about. It was that people were criticizing the author list on that paper.
And so Mani's paper is really great.
Yeah.
And we will be publishing some work on post-progression. So stay tuned.
Coming soon.
Stay tuned.
On that positive note.
Thank you, Vinay. See you next time.